Covering the stories that impact your life, your town, your state, and your future. This is the Means Report with your host, Brad Means.
Hello, everybody, and welcome once again to the Means Report. We appreciate you spending part of your day with us as we continue to talk about the pandemic. Who knew, right? Back when we first started talking about this crisis in, late February, early March, that we'd still be on it today, but we are, and we have a focal point for today's edition of the Means Report that we know you'll find very interesting. It stems from a recent op-ed piece written in the American Journal of Public Health, published there from two local doctors. They're both with us today from MCG at AU, and they're going to talk about the health risks when it comes to the coronavirus, especially when it comes to our minority community, our African Americans adversely affected by this disease compared to other groups. Well, yes, they are. And these doctors are going to talk about that in depth with us and help us explain why and what's needed to remedy that. We're going to kick it off with Dr. Stephen Coughlin. He's an epidemiologist and he is with MCG's Department of Population Health. Dr. Coughlin, I look forward to being together with everybody in person in the studio one day, but thanks for Skyping in with me today.
Yes, my pleasure.
Let me first of all just ask you about healthcare being colorblind. A lot of us might think that it is. My guess is you think that we have a long way to go there.
Well, some segments of the population have better access to healthcare than others, and the Medical College of Georgia and Augusta University Health have been leaders in this area in the CRSRA and throughout the state of Georgia and surrounding parts of South Carolina.
So just to set the tone right off the bat, you believe, and your colleagues at MCG at AU believe, that more African Americans are likely to get this disease and die from it and not have access to the same treatment others do. Is that an accurate synopsis?
Yes, that's correct. Overall, African Americans have about a threefold increased risk of dying from COVID-19 as compared to other Americans. So these are pronounced health disparities. And here in Georgia, the disparity exists, but it's not quite as pronounced as in other parts of the U.S. But in our editorial, which appeared in the American Journal of Public Health today, we summarize information from across the United States, looking at incidence rates of COVID-19 and mortality rates from the disease. And we found that there are pronounced disparities by African American race in each region of the country. So this is very important to address in the midst of a severe pandemic. And we hope that our editorial will draw attention to the need to do more to address these important health concerns.
All right, so let's try to figure out why here. Let's start with testing. Is it just that testing is not as readily available to that segment of our population, the African American segment? If so, why isn't it? You know, I think about the situation in Augusta. You drive down to Christenberry Fieldhouse, you get tested. Is it not that simple for certain parts of our community?
Well, not everyone has access to transportation. They may have to take a bus or get a ride to go to a testing site. Augusta University Health offers screening by telephone or online. So there are resources to get screened for COVID-19, even if you lack suitable transportation. But an example of a structural problem that may contribute to disparities in the disease. In some parts of the country, they've had drive-through testing sites for COVID-19. Mm-hmm. But if you lack an automobile, then that's not an accessible way to get tested.
Is that the same kind of scenario when we look at treatment after you've been tested and diagnosed and then you try to get treated for this illness? Is transportation and our other factors obstacles to getting what you need?
Well, that's a complex question, and part of the answer is that we know that among individuals who test positive for COVID-19, African Americans are more likely to be hospitalized, so they have a higher hospitalization rate. And we also know that there are population differences in health insurance and access to routine health care. Many African Americans work in service industries, and they may lack paid leave or health insurance. So it's likely that individuals are showing up late rather than earlier at emergency rooms and seeking health care later than is recommended. So these structural problems and disparities don't just affect COVID-19. They've been identified for decades for such diseases as cardiovascular disease, high blood pressure, asthma, diabetes, and so forth.
Yeah, I'm going to talk to your colleague, Dr. Hobbs, about those other illnesses and how they impact African Americans in a moment. But what about outside of the workplace for those people, for that segment of our population? Do we see disparities when it comes to their home life, houses, neighborhoods, communities that might limit that access to health care for our African American neighbors?
Well, the initial reports that African Americans were more likely to get COVID-19 or to die from the disease were in January, February, March. And at that time, the public health surveillance data were very inadequate. And there were scattered reports in various parts of the country, mostly in the Northeast and the Midwest part of the U.S., indicating that pronounced disparities did exist. And these were in cities such as Philadelphia, New York, Detroit, Milwaukee, and so forth. Chicago was another one. These cities have large African American neighborhoods that are very crowded, and the households were often multi-generational households, for example, having elders living with younger people. So this increases the difficulty of social distancing when you have substandard housing or crowded living situation. And it's also true that many African Americans live in areas that are less urban and also have an increased risk of COVID-19. This includes parts of the southern United States, North Carolina, South Carolina, Georgia, Mississippi, Alabama, Texas. It's important to point out that when individuals work in areas such as fast food restaurants, grocery stores, public transportation, public works, that it's very difficult to practice social distancing. So in our editorial, we've emphasized the importance of providing culturally appropriate, tailored health education to let people know how they can protect themselves through hand and surface hygiene. That includes hand washing, avoiding touching the face, wearing a mask when out in public, and staying 6 feet apart from others, especially in crowded locations like grocery stores or pharmacies. So an example of that is in Las Vegas, Nevada. The local health department has started culturally tailored public health messaging to inform people in the African American community there how they can protect themselves.
We're going to let Dr. Hobbs continue what you've pointed out in our next segment, Dr. Coughlin, but let me just jump in and say thank you for what you're doing. And it is my hope, I'm sure you share this hope, that some of these disparities that you've outlined decrease and that we can have equality in health care. Thank you for what you're doing to help us get there.
Yes, our pleasure.
Dr. Stephen Coughlin with MCG at AU, our special guest today. And as mentioned, the living legend himself, Dr. Joseph Hobbs. You all know him. He's going to talk more about the coronavirus and its impact on our African-American communities, not just here, as Dr. Coughlin pointed out, but across the country when the Means Report continues. Welcome back to the Means Report. We appreciate you staying with us as we continue to talk about the disparities that exist when it comes to the coronavirus and the testing and treatment options available to our minority communities across the country, especially African Americans. And I'm so pleased to welcome back to the Means Report our next guest, Dr. Joseph Hobbs. Dr. Hobbs, the Chair Emeritus of MCG's Department of Family Medicine. I know most people in the community know him. Dr. Hobbs, thank you for your service to this community, and thanks for joining us again.
Thank you.
And congratulations on your recent retirement. How's it going so far?
Great.
Well, I would like to ask you to come out of retirement for about the next 12 minutes and help walk me through these disparities that you and Dr. Coughlin have covered in the report that was published recently. And I know that you and I have talked about this before. It's not just the coronavirus that adversely affects African Americans more so than others. Haven't you seen this in other illnesses?
Yes, it's this particular pandemic basically showed yet again issues related to the most vulnerable populations among us. Those are people who are challenged by socioeconomic issues, education, employment. Because of all of those things, they tend to find themselves working in the service arena where they can't social distance. And as a result of that, they have a higher likelihood of having contact with the virus. They also cannot shelter in because often the jobs that they are performing are essential jobs, and therefore they have to be out in the public, and they're kind of a part of our front line workers that are essential to keep our society up and going with food services and mail delivery and all the other things that are so essential to make things work. The thing that creates the disproportionate representation of individuals in that population also creates what we call health disparities. And so we are already aware that Black and brown populations are disproportionately challenged by health disparities. And as a result of that, their health outcomes are poor. They have more chronic disease. Life expectancy is shorter. And a lot of these things are really based upon the structural situations in which they live. This is not anything about biology, but rather their access to services. Just because they don't have the resources to do so, even if they're employed, if they're working in an hourly arrangement, getting to a doctor for preventive services may be difficult, so they can't participate in the preventive services that may be available.
So what do you think, what is a solution? And it sounds like it almost what we're looking for is a complete overhaul here of our approach to healthcare to make sure that everyone has equal access. But what are some solutions that you see to help resolve this? Is it having more testing available? Is it building more hospitals so that people don't have to travel long distances to get to one, especially those who don't have transportation? How do we fix this or make it better?
Well, I think that there are things that we need to do acutely. If we're looking at the pandemic as kind of the subject here, is we need to be able to know the demographics of the patient populations that are disproportionately affected. We need to make sure that we get services into those settings that help people to understand the important things they need to do to avoid transmission of the virus. And likewise, trying to find ways in which those communities can, if they have a positive test or someone becomes ill, that we can do the sort of contact tracing within that community to make sure that that we can mitigate transmission of the disease any further. So the big issue here is to make sure that for that population, that we can identify them by, let's say, ethnicity, or if we can identify them by logistics, like where they live, we can make sure that testing resources are made available to them in the context of their ability to use those testing resources. I would think that evening hours, things that are located in public areas within communities that have a high concentration of minorities, African Americans, or other minority groups that might be disproportionately affected. That kind of takes care of trying to get on top of the identification of this disease process. But more importantly, is that we have to find ways, I believe, to try to make sure that the thing that creates the health disparities that existed before there was a COVID-19, that we address those two as well. And so how can we address this? I think that as long as we live in a society where healthcare is not evenly made available, we don't have universal access to healthcare services.
Well,
and as long as people access to healthcare services or quality healthcare services based upon their ability to get insurance costs money and things of this nature, until those things are made universally available, then those individuals who are at the lower end of the socioeconomic strata will certainly will continue to have difficulties with being able to access those services in an equitable manner.
Dr. Hobbs, let me ask you this. Do you think that there is a distrust that exists between segments of our communities nationwide, and the government and the healthcare system? Distrust that maybe turns into reluctance to seek testing or treatment?
Yes. Unfortunately, that does exist. It exists historically because of some of the things that have happened in medicine that did not necessarily respect the situation in which minority individuals find themselves. A lot of people will point back to the Tuskegee studies that looked at sexually transmitted diseases, where one population was tested and had access to drugs, the other population did not. Those are the sorts of things that certainly are not done today because we have research ethics that would not let that sort of thing happen. But it's a part of the memory of a lot of communities of color, of situations where the healthcare system, from their perspective, failed them. The other thing that happens to them is that whenever they have interactions with the healthcare system, when they then on the back end of this get the bill, if they are not insured, then that creates for them even a greater challenge for them and their families if they are working on the margins of being able to maintain economic stability in their families. So it's a lot of things that kind of create that sort of reluctance to those in all communities where they are socioeconomically challenged and really struggling on a day-by-day basis just to make ends meet.
Well, so how do we make that struggle go away? Do we look to our churches, places that all of us hopefully trust, to play a larger role? Do we need people to go door to door and teach some of the things you talked about earlier, social distancing, contact tracing, and get people engaged and say, look, you can be healthier, you can have better access if you will just let us hold your hand and go through this together? Is it going to take those kind of, I hate to say this, boots on the ground, everybody says that. Is it going to take that door-to-door approach as well as the role of some of our more trusted institutions, if you will, like churches?
Yes, churches and other philanthropic organizations out there that work in communities of need and things of that sort. Those are ways in which we can address some of the problems with regards to access and things of that sort. However, I think that we also have to be very mindful that some of the constraints that exist out there are beyond the power of these types of groups to be able to get that message out there. And it is the way that our society is constructed, which also says that we need to have advocacy for policy changes within our local government, with our state government, with our national government, that addresses the needs of these populations and their special needs. And these can be things as fundamental as making sure that not only do they have access to living wages, that they have access to education for both themselves to advance, for their children, so that they don't find themselves caught in the spiral of poverty, and really trying to find a way to create an environment where everybody has access to basic medical services. This will go a long ways to addressing the issues of the disparities that we have out there. Many people in these settings really don't even have access to a primary care physician. Mm-hmm. Someone who's going to coordinate their care through all of this, and therefore they find themselves unfortunately having to wait until they have to go and have contact with the healthcare system. And under those circumstances, they are using our emergency rooms, and that's an inappropriate way and an inefficient way to get those sorts of services taken care of. And it's very expensive at the same time. And they're caught with those bills when that occurs. Well, but I would not want to diminish the impact that within the communities, whether these are social activities. Churches have played a large role in disseminating within our community a lot of information about health, trying to make contact with people about how to get essential services. And no doubt, if we can try to do the same thing with regards to this pandemic, which is probably not going to go away in the foreseeable future, it's going to be with us for months and unfortunately potentially a couple of years or so before a vaccine is out there. We have to find ways to make sure that the community is aware, that they understand the issues of prevention, they understand the issues of how to take care of themselves if they become infected, and more importantly is that if a vaccine ever becomes available, when a vaccine becomes available, we have to be able to convince the community that the vaccine is safe and appropriate for them to take, because
absolutely
people are going to be skeptical about vaccinations, because we already have that problem as it relates to the adult immunizations that we give to patients every day.
Yes, sir. Dr. Hobbs, I cannot thank you enough. We're going to have to leave it there for now. I knew that we should dedicate 2 shows to this topic, and I hope that we can revisit it soon. Thank you to you and Dr. Coughlin for helping us understand the disparities and for helping us overcome them. We appreciate you, and as I said, your lifetime of service, sir.
Thank you very much.
Absolutely. Dr. Joseph Hobbs, our special guest on the Means Report.